Good evening, everyone. I'd like to welcome you today to OKA Keen's webinar on knee osteoarthritis. My name is Sabita Baja, and I am this year's OKA Vice President. And I would like to welcome Dr. Monica Malley. She is here today with us to talk about knee osteoarthritis. Monica Malley is a physiotherapist, professor, and university research chair in the Department of Kinesiology and Health Sciences at the University of Waterloo. Monica's research program integrates biomechanics, advanced imaging, and clinical measurement to advance strategies to promote physical activity among older adults with osteoarthritis. This work is supported by the Arthritis Society, Canadian Institutes of Health Research, Natural Sciences and Engineering Council of Canada, the Canadian Foundation of Innovation, and among others. I'd like to welcome Monica, and I'll turn it right over to you to get started.
Oh, thank you so much. That's such a kind introduction, and I really appreciate this opportunity to meet with all of you. So thank you. Thank you for the opportunity for joining you for this seminar series. Today, I am going to talk about knee osteoarthritis, and I'm going to give you a feel for how biomechanics could be useful in understanding how we treat people with this disease. And you'll see that most of my focus leads towards exercise as a potential intervention for knee osteoarthritis. Before I get started, though, what I'd like to do is just acknowledge that I am a settler here in Canada and that my education and my career have been conducted on lands that are the traditional territory of Indigenous people. On this particular slide, you'll see a teal colored locator, and that tells you that I work at the University of Waterloo. And you'll notice that it sits within a gray banded area. That gray banded area represents land that was promised by settlers to Indigenous people in a treaty in 1784. You'll also see inside that gray area a red shaded area. And this is all that remains honored of that treaty today. That's a loss of almost 1 million square kilometers. It is also the location of the first residential school in Canada, where we know over 150,000 children were forced to attend. And currently in that residential school, we know that they're looking for unmarked graves. But I just put my kid to bed. And so I'm grateful that I have the opportunity to keep my family with me. Thank you for letting me have those comments. All right. So I am going to move on and tell you a little bit about what I have planned for this evening. My hope is to give you an update on the definition of osteoarthritis disease, which is the condition that I focus on in my lab. And I'll talk briefly about the disease burden around osteoarthritis and some background on biomechanics in this field. After that, what I'd like to do is talk a little bit about linking biomechanics with joint tissue damage. And I'm going to share with you 2 types of studies that we've conducted in my lab. But to finish up, I'll try to bring it full circle to talk about exercise and how critically important exercise is for people who have this disease. I'll give you an idea of the guidelines that currently exist around the world around how exercise is best implemented, and then I'll finish off, time permitting, with a couple of comments about how we're using biomechanics to advance this work. So let's get started, and I'll start off by talking about osteoarthritis. In Canada, and likely most westernized countries, arthritis is the single greatest cause of chronic disability among community-dwelling adults. When you think about that, that's remarkable. It's the biggest cause of chronic disability simply because arthritis is so prevalent. By 2026, only 2 years from now, we anticipate that 10 million Canadians will have some form of arthritis. That's a huge segment of our population. Amongst that 10 million, 1 out of 3 will be unemployed because of their arthritis. And even more concerning, people with arthritis are 3 times more likely than their peers to depend on someone else to get through their day. An old estimate, if you want to get kind of mercenary about it, is that we spend about $18 billion every year on healthcare costs and lost productivity. So this is a huge problem for Canadians. Now, there are hundreds of types of arthritis. The most common type is osteoarthritis. And over the last 2 decades, we've come to a deeper understanding on how complicated this disease actually is. 20 years ago, we had a pretty simplistic view. We thought of osteoarthritis as non-inflammatory. So we thought that there really was no mechanism to repair the tissue. There was no inflammation. And we centered our understanding of osteoarthritis on cartilage. We essentially thought we just wore it out through excessive use. At the time, we identified this disease mainly with X-ray. Note that X-ray can't see cartilage. So we really were just looking for signs that cartilage had broken down through joint space narrowing. In the slide on the bottom left, you'll see an arrow on the right-hand side that's indicating how much space is between the femur and the tibia. And on the left-hand side, you'll see that there is no space between them. So we just presumed that whatever cartilage was supposed to be there is now gone. X-rays also identified osteophytes. And so there is this little white arrow. An osteophyte is a bony growth on the margin of the bone, and that could have been an indicator of osteoarthritis disease. If we fast forward 20 years to now, we have learned so much more. We now understand that osteoarthritis affects all joint tissues, not just cartilage. We also see degenerative changes in bone, in the menisci, the synovium, in the muscles around joints. We've also learned that this is an inflammatory condition, and it involves abnormal metabolism of tissue as well as injury. The most recent definition, if you're looking for it, I've given a web address for it. The most recent definition for osteoarthritis identifies that osteoarthritis is a disorder involving movable joints. It's characterized by cell stress. So the cells are being damaged in some way. And this damage or stress is initiated by micro and macro injury. What happens is we have the cell in the center of this image is that we are unable to repair tissue as quickly as it's being degraded or broken down. And the little fire symbol is to indicate that the inflammatory process is simply not capable of making the repair that's needed. And as a result, we end up with this imbalance between the breakdown and repair of tissues, which leads to osteoarthritis. So all of that definition there really talks about the tissues inside the joint, really talks about the disease itself. We can't forget the impact of the disease on the experience that people have on OA illness. So this particular picture is really old. I took this from an Arthritis Society publication many years ago, and it's pretty unlikely that nowadays we would see someone with this severity of osteoarthritis. You can see that this gentleman's knees are now malaligned. They've become bow-legged or varus. And that's because there's been so much breakdown of tissue on the inside of the knee that the femur and tibia no longer line up the way they should. So we end up with this bow-legged alignment, and that's the disease. But when you look at this picture, don't you wonder where he's going and how much pain he's going to endure to get there? So the illness experience of osteoarthritis often, but not always, often involves pain and immobility. And we believe now that together, these impairments associated with osteoarthritis increase the risk for other chronic health conditions like heart disease, gastrointestinal problems, and kidney disease. And indeed, that is correct. People who have knee osteoarthritis are far more likely to also have these other health conditions. So it's critically important. Not only do we address osteoarthritis for the sake of improving the joint, for the sake of improving quality of life for these folks, but we're also aiming to help them maintain as much health in their whole body as possible. So what I'd like to do next is talk a little bit about how biomechanics plays a role in understanding this disease. And this is a picture of my old lab, trying to show some pieces of equipment that we use to evaluate the way people move. We use cameras to capture the motion of the body as it moves. On the floor, it might be difficult to see, but there are force plates, which are really just fancy weight scales that give us an indication of how much force the body is applying to the floor. And we use these pieces of information along with estimates of the person's body size to calculate what are the forces and what are the torques that are being experienced by the knee joint. And when we do this work, we end up with gads and gads of data. We have tons of information. And so far, the majority of the biomechanics work in knee osteoarthritis has focused in on one particular variable. And this variable is called the knee adduction moment. You could also think of it as a torque. This knee adduction moment, or CAM, describes the tendency that we rotate the tibia inward on the femur. This is the moment that makes that bow-legged alignment that we saw in the picture a couple slides ago. This is what makes people varus. And we understand that the CAM represents the ratio of the amount of load on the medial or inner knee compared to the lateral knee. On the right-hand side of the slide, you'll see a graph that tells us about the magnitude of the CAM along the vertical axis here across one walking stride. So at 0, our heel is making contact with the ground. From 0 to 60% is the portion of our walking where our foot is in contact with the ground, called stance. And then you'll see that this CAM almost disappears during the swing phase when the foot is no longer in contact with the ground. What you'll see is an orange line that represents a group of people with knee osteoarthritis, and a blue line with a group of healthy, older, age-matched adults. And you can see that people who have OA in orange have a bigger CAM. This makes sense. They have more torque that's encouraging that bow-legged alignment. And so this biomechanical variable has been useful and controversial in the literature. From this waveform, from this graph, we typically make use of one data point. It's the peak. And you can certainly see that the people with osteoarthritis have a higher peak CAM compared to people who don't have the disease. But you can also see that there are some other differences. People with osteoarthritis are in stance on their leg for a longer period of time, and they just don't seem to have this dip or this recovery. So is this CAM variable useful? There is actually quite a lot of controversy around this variable, and I'm happy to talk about it afterwards. But one of the most compelling reasons to support the use of the CAM when we study osteoarthritis is on this slide. What we see is that the CAM strongly associates with pain irritability in people with knee osteoarthritis. On this graph, we have quartiles. So we've taken a big group of people. This is data from outside, from another lab at Western University. They took a group of people and they separated them into 4 groups or quartiles based on the CAM. So we have the lowest quartile with a very small CAM all the way up to the 4th quartile who have the largest CAM. And what they demonstrated is that in the group who have the largest CAM, these folks are the ones that experience the greatest increase in pain whenever they go for a walk. And so this association between CAM with pain gives us some certainty that we're on the right track, that the CAM is important to not only the disease itself, but also the illness that people experience, that pain. So I've talked for quite a bit here about osteoarthritis and the biomechanics associated with it. What I'd like to do next is tell you a little bit about the work we've done in my lab. And the work I'm about to share with you really belongs to the wonderful group of people I've shown to you here on this slide. This is a group of wonderful trainees that I've had the privilege of working with, and they've worked really hard at showing links between biomechanics and joint tissue damage inside the knee. So early in my career, I wanted to do something different. I wanted to contribute something that was a new perspective around biomechanics and knee osteoarthritis. And so I wanted to explore not just the peak CAM. I wanted to understand what the total exposure to CAM was during a person's day. And I did develop a really crude measurement of the total exposure people have to CAM. And I called it the cumulative knee adductor load. This is simply the product of how much CAM people experience during one step and the number of steps they take during the day. So we brought people into the lab, and on the left-hand side, you'll see a CAM curve, similar to the one I showed you before. But instead of grabbing the peak value, we actually integrated or took the area under the curve to get a sense of what the total exposure to CAM was during one step. And then we multiplied it by how many steps people took during the day. On the right-hand side of the slide, you'll see data from an accelerometer that's just captured steps across someone's day. So could this be useful? Could it add something new to people understanding osteoarthritis disease? What we discovered was that cumulative load was indeed useful. On the left-hand side of this slide, you'll see I've plotted cumulative load for 2 groups of people, a group of healthy adults and a group with knee osteoarthritis. And what you'll see is people who have knee OA had a way higher cumulative load during the day compared to healthy adults. I also wanted to see if it did a good job compared to the peak CAM that most biomechanists were using at the time. And so for the very same 2 groups, healthy and folks with knee OA, I plotted their peak CAM. And certainly you can see that the peak value is larger in people with knee OA compared to the healthy group. But the difference between the groups is a little harder to detect. So as a new idea, I was pretty excited at this idea of cumulative load, that it was helpful in distinguishing who had OA and who didn't. I was also interested though, in taking a look at the two terms I used to calculate cumulative load. Remember the CAM across one step and the number of steps they took in a day. So I'll show you what that looks like. Same two groups. And on the left, I have the impulse of the CAM, the area under the curve. And what you can see is that during a single step, people with knee OA endure a lot more exposure to CAM compared to their healthy counterparts. What's interesting here is the people with OA didn't walk as much as their healthy counterparts. Now, that's not particularly surprising. If you have a painful knee, you probably won't feel like walking as much. What's interesting, though, is remembering that even though they're less active, they still had a larger cumulative exposure to CAM in the day. So they still got a huge dose of this CAM. Now, this particular study has been replicated and very recently replicated in a large epidemiological study in the United States. And what they were showing is that people who had really high exposures to loading, which I've tried to highlight with the teal colored rectangle there, people with a high exposure to loading, high step count, and high BMI had a greater risk for worsening knee cartilage over 2 years. So this idea of cumulative load seemed useful inside our lab, but also outside our lab. So that's all fine and good. It sounds like we can separate out people who have trouble versus people who don't based on the CAM. Can it tell us any more about the disease itself? So one big question we wanted to tackle was whether or not biomechanics was truly linked to the breakdown of cartilage inside the knee. At the bottom right of this slide, you'll see an MRI image. This is an image of a really healthy young knee. And what you can see here is a side view. We've got the femur at the top in that black area. And beneath it, beneath the femur, we have the tibia. And you'll see bright white line around those bones. And that's cartilage imaged here on MRI. So we decided to follow a group of people for about 3 years to discover whether their biomechanics at the beginning of the study could predict who was going to have worse cartilage 3 years later. And I'll show you what we found here. Okay, on the vertical axis, I have the amount of change in tibial cartilage over that 3-year period. It was actually 2.5 years, over the 2.5-year period. And so people who had no change in their cartilage sit at 0. People who lost cartilage over 2.5 years are below that line. On the horizontal axis, I've plotted for you the CAM peak. And so people who have 0 CAM have very little exposure to that torque that makes that bow-legged alignment. And people who have a CAM of 0.8, that's really high. I've split the sample into people who had a healthy body mass on the left and people who had who were either overweight or obese on the right. And we were startled by these results. We were startled by these results because of the influence of BMI. It looked as though on the left, people who had a healthy weight had kind of no relationship between CAM and the amount of cartilage lost. You could actually argue that there's a slight positive relationship here, and I can talk about the reasons why we think that's there. But amongst people who are overweight or obese, a dramatic negative relationship was observed, where in this group of people who are overweight, we saw that the higher the CAM was, the less cartilage or the they would lose cartilage over 2.5 years. And the strength of this relationship was remarkable. So we came to understand that the biomechanics are heavily influenced by obesity. So why is that? Why is a high BMI a problem in people with knee osteoarthritis? Well, one element is, of course, more mass that people have to carry around on their knees. But we also know that there are multiple other impacts of obesity on the joint tissue itself. While we don't really understand how obesity affects bone, we do know that the synovial tissue inside joints becomes more inflamed in people who are obese. And that inflamed tissue starts producing more markers to promote inflammation. So we get this positive feedback loop. We also know that obesity is linked with cartilage loss, and that there is pro-inflammatory and catabolic, so mechanisms that break down cartilage that are associated with obesity in people with knee OA. So we think that the combination of lots of loading on joints that have unhealthy tissue is the reason why obesity seems to accentuate the role of biomechanics in this disease. We did a similar, well, we wanted to look at this a little bit more deeply, and we took a look at using computational modeling to calculate the forces that are actually happening inside of the knee joint. And so what you see here is an example of data we collected on some healthy young women who were all actually quite fit. And we calculated using biomechanical variables we collected in the lab how much force was exerted on the knee joint. We wanted to relate this force in the knee joint with what was actually observed inside the tissue of the knee. And so we took an MRI of people, of these young ladies, as after they rested at the MRI suite. And I'm going to show you a picture of the cartilage that we measured from that baseline measurement. What you can see here are the femoral condyles, just the cartilage on top of the femoral condyles. And underneath it, you see two plates, and that's the cartilage on top of the tibia. So we had an idea of how much cartilage these young women had. They all had healthy knees. And then we asked them to run. They ran for us for about 15 minutes on a treadmill, and we measured the amount of cartilage they had in their joint immediately after. What we were looking for was how much that cartilage squished. So we were really interested in how deformable and squishy that cartilage is. Now, we don't want people to have really squishy cartilage. We want that cartilage to be resilient and firm. And so let me show you what we found in healthy young women who do not have osteoarthritis. And I'll take you through this graph step by step. Along the horizontal axis, I've got the number of steps per day they completed, and we captured that with an accelerometer. And so you can see some people, some of these ladies were not very active with only 3,000 steps per day, and we got up to about 9,000 steps per day in this sample of women. On the vertical axis, we have how squishy the cartilage was. If they didn't have much cartilage squish at all, they sat at 0. If they squished a little bit, we went down about 200 cubic millimeters, all the way down to, it looks like, down to 400 cubic millimeters. And then finally, we plotted this sample we plotted the lines of this sample based on their BMI. The purple lines are for our lightest participants, and the yellow line is for our participants that were overweight. What we saw was that among the group that were overweight in yellow, that the more physical activity they engaged in, the squishier their cartilage was less resilient. And so even though they didn't have osteoarthritis, we could see this interaction between their biomechanics and obesity, that obesity makes our tissues less resilient. So I'm going to stop talking about these detailed studies, and I'm going to move on and tell you a little bit about exercise and hopefully give you some information that you can use in clinic tomorrow. And I'd like to acknowledge and thank the folks that are on this slide who've contributed greatly to this work. So first, I'm going to start off with the most recent clinical practice guidelines on how we should be treating knee osteoarthritis. And I'm going to focus on non-surgical techniques. So I've given you, or I've created a table to show you guidelines from around the world, including Australia, an international organization called ORSI, the European organization, and the United States. And what I want you to notice is they're pretty consistent in terms of the recommendations that they've built from research. All of the clinical practice guidelines say that the core treatments for knee osteoarthritis include education, exercise, and for those who are overweight, diet. And so we know that the first line treatment for these folks includes exercise, and I'm going to focus the rest of this talk on exercise. Having said that, you'll see below there are some other approaches that these clinical practice guidelines highlight. Some of them are cognitive, including self-management techniques, cognitive behavioral therapy, and mind-body techniques like Tai Chi, yoga, and other mind-body tools. And you'll see that the clinical practice guidelines have more variability here. Green means strongly recommended, and then yellow or light green means kind of conditionally recommended. And so you can see there's less consensus, and a lot of the reason why there's less consensus is because there's less research on these particular tools. Below that, you can see clinical practice guidelines generally recommend use of a cane where it's indicated, that bracing can be useful, and that techniques like hot packs and cold packs could be useful as well. And then finally, all the guidelines recommend analgesics, including non-steroidal anti-inflammatory drugs, either oral or topical. But the bottom line here is that there's a lot of consistency between these organizations saying that exercise is a must-have. Now I'm going to zoom in a little bit. I'm just going to pick one of them, one of these clinical practice guidelines, and I'm going to show you a little bit more about the American College of Rheumatology and what they recommend. So on the left-hand side of this slide, you can see their recommendations for hand, knee, and hip osteoarthritis. And right at the top, first-line treatment is exercise. Below that, they're recommending self-management programs, and for the lower extremity, where appropriate, weight loss, mind-body, and adjunctive therapies like canes and braces. On the right-hand side of this slide, you'll see what they recommend against, and they strongly recommend against the use of TENS. And they conditionally recommend that we do not use these other techniques that are in pink, including manual therapy, with or without exercise. And I'll have a comment about that later on today. Massage therapy, altered shoes, and other techniques. So I'll ask you to think about your clinical practice and how it aligns with these clinical practice guidelines. But certainly exercise is the core. So from the literature, what are the principles when we have someone who has knee osteoarthritis in terms of the best approaches for exercise? And the literature suggests that what we want to focus on are functional, weight-bearing activities. So getting people to do sit to stand, to walk, those sorts of exercises are probably preferable to putting them on a weight machine to do knee extensions. That flexibility and lower leg alignment is critically important, that we want to encourage people to be body aware and use the as neutral alignment as possible. The literature suggests that people with knee osteoarthritis will likely continue to experience pain during their exercise program, and that is normal and acceptable as long as the pain does not exceed 2 additional points from baseline. So if they come into exercise at a 4, and by the end of their exercise program, they are at a 6 out of 10 out of pain, that is acceptable, but no more than that. We know that supervised exercise is more effective than home programs. And there is some debate about whether or not we should do multimodal exercise, meaning should we have, excuse me, should we have people do resistance exercise and aerobic exercise? And I would say we're still learning the answer to that. In terms of actual dosage, the most common exercise that is researched is strengthening or resistance exercise. And on this table, I've broken down for you the recommendations for resistance training or strengthening programs for healthy adults, older adults, and adults who have hip and knee osteoarthritis. And what you'll see is a trend in our fit or a trend in our dosage, where as we go from healthy to OA, we increase the frequency and we reduce the intensity, and we move from complex movements to simple isometrics. So for folks with knee osteoarthritis, a little bit of exercise can actually help quite a lot. Increasing the frequency and keeping the exercise tolerable, a low to moderate intensity will make a difference. And we encourage people to not be too concerned about how hard they're working, just as long as they're doing something. So I noticed I have about 5 minutes left, and what I'll do is tell you a little bit about some of the exercise research we've done in our lab, and I'll finish up with a summary of recommendations for exercise. So we were really interested in the idea of functional exercise, an exercise that was weight-bearing, and we decided that we wanted to build an exercise program that minimized the exposure to CAM. And this was in light of our work on cumulative load. We wanted to give people the opportunity to strengthen their knee muscles without worrying about accumulating a lot of exposure to CAM. And so we set about looking at biomechanically informed strengthening exercise, and we decided to position it in yoga. And so what you'll see are pictures of different yoga postures, and we evaluated a variety of yoga postures in our lab to determine how much CAM was experienced during these exercises. And on the next slide, I'll show you what we found. On the vertical axis, I have the CAM magnitude. And so again, you have 0 where there's hardly any exposure to CAM. You can see some exercises, like this green one here, had a higher exposure, and other exercises actually encouraged a valgus or a knock-knee type torque, which we thought would be acceptable. But ideally, we wanted exercises that fell close to 0 on this graph. The horizontal axis here is quadriceps activation. We really wanted to strengthen quadriceps. And so we wanted to get people as far to the right on this graph as possible. And so what our data showed us is that squatting and lunging activities were actually really ideal for people with knee osteoarthritis. And we put together an exercise program that emphasized squats and lunges as a key component of an exercise program. Once we did that, we tested it in a small clinical trial. We randomized a group of older women with painful knee osteoarthritis into 3 groups. The first group received our biomechanically informed yoga exercise program. The second group received traditional physiotherapy. And the third group was an intention control group. So we wanted to see them as frequently. We wanted to give them the chance to meet with an instructor, but do something non-physical. So they received meditation as a control group. And after 12 weeks of exercising 3 times a week, we saw changes in pain and mobility across these 3 groups. On the right-hand side of the slide, you can see the biggest reduction in pain was observed in the folks that did our yoga program that was biomechanically informed. And that this pain relief was more compared to people who got no exercise. It was about the same as traditional physiotherapy. And very similarly, we saw that people experienced an improvement in their mobility in both the yoga and traditional physiotherapy programs compared to people who got no exercise at all. So with that, I am going to stop there. Forgive me, I'm going to slip through a couple of slides. And I'm just going to end on this summary slide. This work was a reflection of a huge effort from the majority of my research team, as well as colleagues at the University of Melbourne. We took a look at all of the literature we could find on resistance exercise in knee osteoarthritis. And what you see here are the results of 280 studies in knee osteoarthritis and exercise. What we were looking for in these studies was what is the right dosage to reduce pain in people with knee OA. And what we found is that in people with knee OA, as well as people with hip OA, the ideal dosage is to exercise people anywhere from 3 months to 12 months. And any exercise program that had that duration generally decreased pain and improved physical function. So we do want people to commit to an exercise program for 3 to 12 months if possible. What was interesting and controversial is we found no actual prescription was associated with better pain relief. So the volume of exercise, so we thought, the more you exercise, the more pain relief you're going to get. That is not the case. That is not what we found across this body of literature. We also found that their adherence to the exercise program that was prescribed didn't matter. This also blew our mind. So it didn't matter if they adhered to what you prescribed or not. So our key message here is, don't get too wrapped up in giving a perfect dose. Just get them moving. And if we can get these folks moving and doing something for a duration of at least 3 months, they are likely to experience benefits to pain and physical activity. So with that, I'd like to thank all of you for your kind attention this evening. I'd like to thank a group of wonderful trainees in my lab that I have had a great privilege to work with, as well as some collaborators who have made this work possible. Thank you all so much, and I'd be so pleased to answer any questions you have.
Thank you so much, Monica. At this time, if anybody has any questions, they can feel free to place it in the Q&A box at the bottom of the screen, and we will get to them right now. We do have a question already, so I will kick us off. The question is, if lower leg alignment is important, why are orthotics not recommended?
Oh, that's such a good question. Thank you so much for this. So, you're right. This is a great, and you framed it so nicely. I fully believe that lower leg alignment is critically important when people exercise. We really want them to have healthy mechanics when they exercise, although that systematic review we did suggest that might not matter so much. So, why don't orthotics work? Uh, or why aren't they recommended? What we see is that orthoses in shoes reduce the cam. They reduce the cam by about 10%. And so while 10% is good, it may not be clinically meaningful. So one reason why I think the orthotics do not make the cut into clinical recommendations is because the magnitude of improvement is so small. The American College of Rheumatology also took into account the investment from the patient. And so, for the benefit received, the cost of the orthotic is what they considered, and they believed it wasn't worth that investment. Part of the picture is also that there isn't as much research on orthotics as there is on exercise by comparison. So we feel really certain, without question, exercise works. But we don't have quite as much research on orthotics at this point in time. And so perhaps with time and perhaps with better tailored orthoses or better tailored protocols, we could increase the effect, like increase the improvement. And it's also possible that we can reduce the cost of these devices to make the ACR change their recommendation. But for the time being, they're saying this is not a useful investment.
Awesome, thank you. Okay, next question is, what factors do you find are main precursors to individuals requiring a manipulation post-total knee replacement when their functional knee range is extremely limited post-op?
Okay, this is a fabulous question. Thank you for this question. And I am going to say that I am not an expert on total joint replacement and the rehabilitation protocols surrounding total joint replacement. Having said that, I do understand that there are precursors or there are predictive factors for people who are going to have a poor outcome after a total joint replacement. The number one is it a revision? Have they already had a joint replacement? And for whatever reason, it could have started to loosen. Loosening occurs when the bone stock that the joint replacement is placed within becomes weak. So people with osteoporosis, people with diabetes, and that joint replacement stem starts to wiggle inside the bone, and they end up having to have it their replacement revised or replaced again. So this is their second turnaround in joint replacement. The other one is if they acquire an infection around the joint replacement. And so these two are critical factors leading to a poor recovery post-op. There probably are some others. As far as I'm aware, and again, I'm not fully versed on the literature, factors like obesity or surgical technique, things like that, do not seem to be linked to the total range of motion that people have afterwards. And the last thing I'll say is, like, I remember in my clinical practice, and it's been a while, it felt like there were so many that needed manipulation after a total joint. But the reality is, we do thousands of these surgeries in Canada every year, and the proportion that actually need that extra care after the joint replacement is small. It's just that those are the ones that we end up seeing, right? Like we see all of them. The folks that do really well basically go home, they have a home program, and then they move on with their life. And so I just want to say that um, it, joint replacement is a highly, highly successful surgery, and these complications are somewhat rare. I hope that was helpful.
Awesome, thank you. Okay, next question we have is regarding exercise progressions. Is there a difference in the management of those with osteoarthritis patients with pain or those who are not in pain?
That's a great question. Love it. So, interestingly, not everyone who has osteoarthritis has pain. And so, if we took a segment of the population and we x-rayed them or we put them in the MRI, we're going to find a whole bunch of people, probably just over half have osteoarthritic changes. So, they would meet the diagnostic criteria, but are pain-free. They'd have no idea that they had OA. And so, yeah, we can exercise them differently. Those people who are asymptomatic, I would say, fit within the guidelines for healthy adults when it comes to exercise prescription. And what becomes quite nice for them is we don't have to tailor their program to manage the pain, irritability they might experience, that others might experience with exercise. So I think I would move that asymptomatic group into just regular exercise as though that disease wasn't there. MRI studies tell us that exercise does not create damage inside the joint. So even if they have OA changes and they're pain-free, I would not be afraid to exercise them. For people who do have pain, we respect the pain. We want them to stick with their exercise for at least 3 months. We want them to have the confidence that they can keep going without making their joint worse. So we want to scale our prescription to encourage them to keep going. And I would say, meet their lifestyle, meet their interests, and help them figure out what they're going to stick to, and then respect the pain by making sure they know that a 2-point increase in pain is acceptable from the beginning to end of their exercise program. And any more than that requires some tweaking of their exercise program, reducing the duration, reducing the intensity or the frequency until they can exercise within that 2-point range.
Awesome. If there are no more questions for this evening, one just popped up, last but not least. What is your view on the use of unloading type knee braces as a realignment tool to help alleviate pain and to try to increase their overall daily movement?
This is a great question. And in my response, I'm going to circle back to the orthosis question as well. So knee braces work and they produce about a 10% reduction in the CAM, and they do reduce pain. I was really intrigued when the American College of Rheumatology made the recommendations that they said yes to braces and they said no to shoe orthoses, because the size of the effect is equivalent and the cost of the brace is more. And so I think this is a feature of there is more research and there are quite a few options for unloader knee braces. They have very low risk as long as they're fitted properly, and I do think that they work. Having said that, you do have to manage the cost and the adherence to wear with the benefit that people receive. So I would say if people have the means to access a knee brace and would like to try it, go for it.
Awesome. Okay, so we'll wrap it up there. If anybody does have any further questions, feel free to email us and we'll be sure to forward them to Monica and get those questions answered. I'd like to take the time to thank you so much, Monica, for giving us this wonderful presentation today and being a part of our evening. And thank you all for joining us as well.
It's been a pleasure. Thank you for having me.